First up to say welcome to Zoe Wilson. She qualified around about 6 years ago, Zoe, and since then you've been focused on developing your private practice in Cumbria in the Lake District. I have visited, but of course it was winter, so I look forward to going back in the summer and doing a little bit of hiking up into the wonderful Lake District there and getting high on some of those peaks and maybe get a swim in one of those lakes, which would be spectacular. So Zoe's been working away in Cumbria, developing her private practice. And from my perspective, I would say that Zoe is a person that just demonstrates a huge spirit of generosity. So she's really, really keen to work with people, to learn as much as she can so that she can help her patients and improve patient outcomes. So I think that's one of the key things, and she kind of wears that on her sleeve. She's got this huge heart to just connect with everyone. So I think people, if you need to, in terms of getting further information on adult acquired flat foot and Richie Brace therapy, you can certainly reach out to anyone in Firefly, but I bet Zoe's willing to take some questions and help as well. Okay, so I suppose the other thing to say is that my name's Martin McGill. I'm a podiatrist and have been now for nearly 32 years, which is a bit scary. And I'm the founder and managing director of Firefly. Our role is really to focus on MSK, podiatric biomechanics, orthotic therapy, and specifically also ankle foot orthotic therapy, which is kind of a new area for podiatrists over maybe even the last 10, 15 years, where we're slowly being able to treat more complex pathologies and making a huge difference. So Zoe, if you're happy to go ahead and share the presentation, and then we can move on to our questions after.
So yeah, first of all, thank you very much for asking me to come and present on my favourite pathology to treat. I'll start with. So we're going to be talking about adult acquired flat foot and the Richie Brace today. And yeah, we'll open up to questions at the end of my presentation. So do feel free to ask away. So I'm going to cover anatomy and pathophysiology of the condition. We're going to have a quick look at classification, the underlying causal factors that are well reported within the literature, my wonderful case study of a lovely lady I've been treating for a couple of months now, my AFO prescription, so my Richie Brace prescription, briefly going to cover a little bit on rehabilitation because I think it's paramount for these patients. And the good old references will be in at the end. So first of all, just going to start with a definition. I really liked this one because I just felt that it kind of covered all bases. So adult acquired flat foot, or AAFD, formerly described as posterior tibial tendon dysfunction. It's a debilitating condition with complex pathology defined by the collapse of the medial longitudinal arch of the foot and continued progressive deformity of the foot and ankle. And that was Arain, Harrington and Rossenbaum 2020. So the anatomy, this bit obviously interests me immensely because it's quite a complex condition, but you know, we do need to discuss all of the factors associated with the anatomy. So of course, the posterior tibial tendon attaches primarily onto the navicular, but also has multiple attachments through into the foot, which I wasn't fully aware of until I looked further into this. Origin being the posterior aspect of the proximal tibia, fibula and interosseous membrane. It then makes an abrupt turn underneath the medial malleolus and has these three attachment points, so three different arms. So primarily the navicular, but also cuneiforms 1 and 2, the cuboid, the bases of METs 2 to 5, and also the sustentaculum tali, which leads me on to my next structure, the spring ligament. So it supports the head of the talus, and we're going to talk a little bit during my talking about the classifications about the less than 30% talar head uncoverage and more than 30%. So that will feed nicely into the types and the stages we're going to discuss. But basically the spring ligament attaches onto the anterior aspect of the navicular and the sustentaculum tali. So it's round about that area of the posterior tibial tendon and hugely important in the stabilization of the rear foot. The deltoid ligament, as you can see, the bottom right picture has 4 ligaments. It's got 4 different attachments. And again, stabilization of the medial ankle. So a hugely important structure here that we cannot ignore. And I think you'll agree that this part of the foot is fairly complex. And I described it last night as a little bit of a spider web coming into the foot. The role of equinus, we've got to talk about it. Lots of these patients have an equinus. I typically tend to do a silver scald test, which I'm sure lots of you are aware of in clinic. But generally an equinus will increase that hindfoot valgus, accelerate midfoot collapse and forefoot abduction. So, pathophysiology. I think it's important to note that this tendon has a section of hypovascularity, and that is 2 to 6 centimeters from the attachment of the navicular, and it's said to contribute to those degenerative changes seen in the posterior tibial tendon. No doubt on that, because we see, you know, a lot of these coming in of a certain age group as well. So generally, we get the posterior tibial tendon dysfunction. That leads to the abnormal load through the tarsus and through the tarsal joints in the midfoot. We then get that MLA collapse, so medial longitudinal arch collapse, an eversion of the subtalar joint. There's unopposed action of peroneus brevis, an abduction of the midfoot at the talar navicular joint. And then generally we have that valgus heel position, and that can be with or without the rigid deformity. So some of the underlying causal factors that I will just cover in brief, but foot and ankle trauma is a huge, so underlying causal factors, as I said, foot and ankle trauma, and I'll speak to you a little bit about that in my case study later on. Obesity, of course, is a factor. I certainly think if you've got a patient presenting with this condition, that there needs to be, you know, a discussion around obesity, you know, if that patient's BMI is higher than it should be. Pre-existing flat foot, of course, family history of flat foot. I think if you're ever assessing any young patients as well, so just having a look through, you know, family, positive familial history. Diabetes mellitus, if they've had any corticosteroid injection therapy around about the tendon. And I will be honest, I've seen a couple of these cases that have already had corticosteroid injection therapy prior to coming for offloading therapy. So it is possible to see that as well. High impact sport. So if we have a flatter foot profile and we have a flatter foot type, we need to protect these patients with appropriate rehabilitation and loading to prevent any injury to the posterior tibial tendon. Arthritis, so osteoarthritis and rheumatoid arthritis, also seen in your seronegative arthropathies such as psoriatic arthritis, and it tends to be more common in females in the 6th decade, which we'll come on to with my case study. What I do think is really important and very up and coming within our practice, and certainly with this condition, is the use of ultrasound. And ultrasound imaging, obviously, you can dynamically look at the tendon. You can also look at neovascularization within the tendon. And I actually had a gentleman who presented bilaterally with this not long ago, and we got some bloods ran because he had it bilaterally, just to rule out any of those arthropathies with his bilateral presenting case. So myosin classification, some of you may be aware of this, some of you may not. But basically the myosin classification in 1997 is the typical classification tool that we use for the condition, or that's the one that I personally use. There are a few others out there. This one has actually been adapted from Johnson and Strom, and they added that 4th stage. So as you can see, there's 1, 2, 3, and 4, and then 2 and 4 have 2 subsections to them as well. So generally, in terms of conservative care, we are generally focusing on type 1 and 2. Now, that's not to say that we're not going to treat 3 and 4. And I've actually read on kind of multiple papers that all of these patients need to be offered that conservative therapy before they you know, do get a surgical opinion. So typically with stage 1, we get the tenosynovitis. There doesn't generally tend to be any deformity on plain radiograph. And then as you start to go down the stages into stage 2, they're getting more moderate pain, and there tends to be a flexible deformity, and they're unable to perform that tiptoe test that we're very familiar with, and I will again cover that at the end. So the type 2A and 2B, we've got the 30%, so less than 30% talar head-on coverage, and that again, will be seen on plain radiograph. But when we start to get to these laterally presenting stages, it's really important, that a good discussion is had with these patients, certainly about surgical management. And for me personally, I tend to treat flexible deformity. I find that they work really well, but not all patients are surgical candidates. And we've got to be aware that if we are seeking a surgical opinion, this patient might have multiple comorbidities, which means that, surgery is not an option for these patients. And I found this lovely reference here that all patients affected by any stage of AAFD should undergo non-surgical treatment before considering surgery. And I think there's a massive drive, both from conservative therapists and surgical therapists, to exhaust these options. And certainly when we've got a 67 to 90% success rate from Alvara's paper in 2006, it certainly seems feasible to do so. So my lovely case study, this lady is 74 years old. She presented with, well, I'll tell you what she presented with in a minute, but a medical history is that she had an eversion injury to her left ankle, and she is obviously over that 6th decade in terms of age, and she does carry, a little bit of additional weight. So all of these factors need to tie into our overall, like remit with prescribing, this type of device, and certainly getting her going with a loading program, footwear advice, the whole lot. So she takes mirtazapine, and she's a fell walker, she's a Nordic walker, and she's a golfer. She's a very active lady. And she presented with medial ankle pain, heel pain, and she had sharp pain in her Achilles tendon, and she did have some pinching pain in the left ankle as well, around about the sinus tarsi, which we do tend to see when we get that medial shift of the rear foot. And it tends to just impinge on that lateral aspect of the joint. She rated her pain as an 8 out of 10, and I'll be honest, she was miserable. She was in tears at one point when she rang me shortly after we did her initial consultation. And you often find with these patients, it's very debilitating, it's very painful, it can be very frustrating and very limiting in terms of what they're able to do. So she'd seen the GP, she'd seen physio, NHS podiatry. She'd been provided with an elasticated ankle support, but she didn't really gain much relief from that. And I think you'll see why in a second. She did get a surgical opinion, but at the time she was counselled by her consultant, and they came to the decision that conservative management would be a good option to begin with. So this is her foot. And I apologise, I didn't get a picture from the back of a heel, but she does have a valgus heel position. Obviously, you can see that MLA collapse through that medial column. And that's, a lot of stresses going through the ankle and foot. And she, as I say, she's in a substantial amount of pain. So we fitted her with a Richie Brace. So this is her Richie Brace on the left-hand side and the right-hand side. And a lot of people will say to you, the Richie Brace, it's really cumbersome, you can't fit it in shoes. Well, there is a good example that a low volume golf shoe on the right-hand side of the picture there, she's playing golf pain-free in that. So, and to the left there, you can see my cast that I've done. So what we're kind of looking for in terms of the cast, and again, I think we'll get some questions on this, so do feel free to fire in at the end. But we're trying to get that nice calc vertical position and that first metatarsal, and the forefoot and the rear foot on a similar plane. And that's providing that you've not got any fixed deformity within the midfoot or the forefoot. So in terms of her brace, she had a standard full articulation brace. Again, we'll talk about the options, question and answers. Casting, calc vertical, so that was that's what I tend to select for all of these patients. We then applied a 4mm Kirby skive to the medial aspect of the device to create that supination moment on the rear foot, and then a heel raise of 2mm. Now, Martin would definitely suggest potentially, if you're having a standard device and not necessarily a low volume, that the heel raise be a bit higher to counteract that equinus if there is any present. And then, yeah, she's got some orthoses for her other shoes as well. And I think it's important to note that these patients should have a contralateral orthotic as well. So briefly then, rehabilitation. So I had a look at a systematic review of the various loading programs and, in terms of advice that there is out there within the literature. And obviously eccentric, concentric, we've got to have a discussion about both because both are important, but eccentric won in terms of superior pain relief, dysfunction, and those functional outcomes. And that was from a relatively recent source of Ross et al. In 2018. So banded tib post strengthening. So again, I think when you've got patients who are in a lot of pain and they can't necessarily do any of the weight bearing exercises, the banded tib post is certainly a great place to start. Eccentric calf loading for soleus, gastroc and Achilles. And single leg loading, it's really important that when you rehabilitate these patients, you're not just giving them the same program for 12 weeks. You know, when they start to improve a little bit, and that might not be until they get their brace, we need to up the weight and we need to up the intensity of the rehab, or it's not going to have its, desired effect long term. Proximal chain assessment, get a physio involved. Is there any hip, knee, back pain? Often with these patients, because of the aggressiveness of the rear foot position, we can't discount the possibility of having proximal chain problems, hip problems, etc. So it is important to get a physio on board, and I think it's paramount to be working with physios. They are the true experts of rehabilitation, and I truly believe a multidisciplinary approach is paramount for these patients. Footwear. Can't stress enough. You all know I love a good hoka. So in terms of footwear, there are various trainer companies that do quite a stable midfoot and just a stable frame around the shoe. Brooks, fantastic. Hoka work really well. There are a lot of leather shoes that, just general everyday shoes that these can fit in as well. So you're certainly not limited there. And last but not least, I'm not going to discount the tiptoe test. So I have just popped that in on the right hand side. So as you can see from the left foot, because the posterior tibial tendon inverts the hind foot and also plantarflexes the ankle, we tend to use this test to determine whether or not that tendon is functioning. And if you look at the right limb, you can actually see the bulge of the medial part of the ankle and the tarsus, but you can also see that heel is remaining in valgus. So that's a positive test for, posterior tibtendal dysfunction. And obviously you'll see on the left side, we've got that nice inversion in a tiptoe. So to conclude, grade the severity of the flat foot, but certainly don't let it determine your ability to offer conservative care. Discuss your patient's treatment options by discussing an effective treatment strategy. Every patient I see gets the conservative surgical treatment ladder. We're all familiar with that. I think it's important to give our patients the information to make an informed decision on how they want to manage their foot pain. So even if the foot is suitable for surgical intervention, your patient may not be. Exhaust the conservative measures before the onward referral and make friends with a local podiatric surgeon who can support you further in the journey of treating these patients. Enjoy and love the process is my final point. It can be limb and life-changing. So thank you very much indeed, and references, and I welcome any questions.
Okay, Zoe, fantastic. Glad to hear you like a good hoka. Nothing like it. Sounds like a dance, but yeah, we know you're talking about a specific type of running shoe. Thanks for the presentation. Really concise. Tends to lead me nicely into our conversation. There's a couple of things that come up for me that I'd like to share with all the people that are watching. First would be, what are you typically like to see? Well, what do you see in the clinic when the patient walks in? From your photograph there, quite often we do see these really flat feet, these really pes planus type of presentations. And, I'm wondering, what do we need to see, or what do we see? What makes you suddenly go to, this is probably an adult acquired flat foot?
Are you asking me?
I'm asking you, yeah.
Okay. So it's funny because I've got stairs up to my MSK clinic, and it's like these little things before they sit down and tell you anything. I'll be honest, I do get a pre-appointment questionnaire out to the patient, so I have a rough idea of what they're coming in before they come in. But patients like this generally, they might struggle with walking upstairs because they need that, that kind of plantar flexion to push on to the next step. So that's certainly something that I notice. And
let me jump in with you as well. Because I've treated a lot of these patients, and the first thing I would say is usually it's a unilateral flat foot, and it's very obviously flatter than the other. And you tend to see, as that last photograph you shared, you do see this medial bulging really around the talonavicular. Because of all of that, you tend to get the deformity in the transverse plane. So you're going to get abduction of the forefoot. You also get then a sagittal plane deformity on the forefoot. So you get dorsiflexion of the forefoot, which means that the foot kind of starts to function more like a primate's foot. It's more like an ape's foot than a human's foot. And what tends to happen is it breaks in the midfoot. So what you see when they're walking is a delayed heel lift and the inability to propel. So they tend to lift one foot, set one foot down, lift one foot, and it's been set down flat. And, it's just apropulsive. So that's a really good thing to look out for. The other thing in your presentation that I thought was really, spot on was the discussion about the spring ligament and the deltoid ligament. I've just read Doug Ritchie's latest chapter in his new book about adult acquired flat foot. And there's a real focus now on ligamentous attenuation, ligamentous disruption. And that's the key thing that happens in adult acquired flat foot. So, a lot of people will have post-tibial tendon tenosynovitis and so on, and may not progress to adult acquired flat foot. And the progression to the adult acquired flat foot is the interruption of the spring ligament and the deltoid ligament. And again, what I learned with working with Doug Ritchie is that when you put them in the brace, over a period of maybe up to 12 months, if you get the patient in stage 1 and stage 2, those ligaments heal. And again, I often thought, you get into a Richie Brace, that's it for life. Now I realize, there are certain patients can come out of the Richie Brace and into foot orthoses, appropriately designed, So the ligamentous attenuation and disruption is really, really key. The other thing that I learned from Doug's chapter is that there's a whole discussion now about whether we actually call the subtalar joint, because there's different facets on the bottom of the talus and the calcaneum, and that in fact there's actually 2 joints there. And one of the things that came up in the research that Doug done for the chapter was that the basically the articulation surface on the inferior and posterior surface of the talus may be what predisposes people to that drift of the talus. And eventually in the end stages, what you see is the talus actually starts to move more medially and off the calcaneum. The calcaneum goes more lateral and the whole foot is really disconnecting from the leg. Another big thing to talk about is just what a brace does in terms of joint coupling. So it actually connects the lower leg. So think about that tib and fib and connecting it to the hind foot, midfoot, forefoot. And that's one of the secrets in terms of how it actually works. The other thing that I think is interesting in your presentation is the discussion of, say, the end stages, where you talk about stage 3 and stage 4 and what options are available. We have treated those conditions, sometimes even with standard Richie braces, sometimes with gauntlet braces. And we've had some interesting results in the sense that you think, right, in those end stages, it's more fixed, more degenerative joint disease. And you think, well, I'm not going to be able to change the alignment, change the kinetics. And yet when you put them in a standard Richie brace, the uprights take the load and they offload the foot and ankle, and it helps. Even though you don't get a change in the alignment, there's a change in the kinetics. So that's exciting. Yeah, what else now jumps to mind there? Let me see if we've got any questions coming in. There's some people really keen to... There's a few people keen to see your presentation after the PowerPoint. So that would be, we'll have to make sure that that's available.
There's just one or two questions in the chat there. I'm not sure if you can see them, but Katrina Macklin asks Zoe, well, first of all, she says, great presentation, Zoe. But she asks, Zoe, do you see any link between leg length discrepancies and adult acquired flat foot as it's often bilateral?
I mean, my answer would be that anything's possible with these patients. You know, I mean, I have, like I mentioned, I've seen a bilateral case quite recently, and we ran some bloods on him and did an ultrasound, and, you know, one was markedly worse than the other, but we were talking about a very degenerate tendon, a very thickened tendon, you know, pain levels kind of up around the 9 out of 10, 10 out of 10 region, you know. And certainly I check every patient, as we all do, for any pelvic imbalance. And I think it's really important that if we do suspect that there's a leg length discrepancy, that we get a second opinion on it as well. Because obviously we've got the involvement of functional. How long has this patient been compensating for this problem? Have they developed a functional change in the pelvic tilt or the pelvic position? And that's giving us a functional presentation. Generally, the way that I have got one at the moment, actually, and he had a femoral fracture in a motorbike accident. And he has developed a adult acquired flat foot on his longer leg. So I think it's interesting to note that it's definitely a factor. We're going to get more generally with a longer limb. If it is structurally longer, we're going to get some compensation through the rear foot. But like I say, like I do involve physiotherapy a lot with these patients because I'm all about getting them as good as they can be, you know. And if there's any kind of anomaly within that pelvic area, yes, we need to address it. I hope that answers your question, Catriona.
Okay, there's a couple of other questions, Zoe, that have come in. The first one comes in from Rosita, and she's asking, I had a patient with unilateral posterior tibial tendon dysfunction with wide redness around the insertion area in the navicular and cuboid area, and a flexible deformity in that area. I wondered whether the redness is common, and if so, what is the source of the erythema? Inflammation of the joint or tendon, or question mark?
Good question.
Yeah, well, maybe I could answer that because I mean, I've seen that, and usually it would be more in the medial side, and it's usually really the bulging of the midfoot, the talonavicular area against the footwear, and you get irritation. So it's simple friction against footwear. Or sometimes at a later stage in the deformity, it's actually on the ground itself. So I think it's that's the cause of it. Unless there was some type of, you know, abrasion and then subsequent infection. But I think it's probably related simply to pressure from footwear, you know. There's another question in, oh, sorry, go ahead, Zoe.
Yeah, I agree with that entirely. And I think, you know, erythema is something that, for me, you know, we've certainly got to look at the age of the patient, maybe the medication that they're taking, the gender of the patient as well, because we kind of can't discount those systemic causes. So certainly if I see erythema or I see lots of oedema around the area, and you certainly see that sausage swelling round about the posterior tibial tendon, I just don't think there's any harm if you have any conclusion as to, is this patient got a systemic cause, you know, certainly referring through the GP in the first instance just to have a look at inflammatory markers. But yeah, I mean, that's like probably over exaggerating it, but yeah, I mean, if something's painful, you get erythema, you get swelling. But yeah, footwear, huge, good, very good point. Yeah.
There's another question in here from David. David saying, thanks, Zoe. If the rear foot is not flexible, brackets correctable, is the Richie Brace still an option? Maybe I touched on that because I still think it is, because of the nature of altering the loading in terms of kinetics. And we've seen that not only with sort of medial collapse of the foot and ankle, but also lateral collapse, where we've seen a young, actually podiatry student who had a tarsal coalition, which was surgically operated on, and the calcaneum was fused in slight inversion. And that's obviously a position you can't alter the angulation of the calcaneum, and yet when we put her in a Richie brace, within 1 week of putting her in a Richie brace, it offloaded the perineals, which was her problem. So the same applies to the medial side, and I have done it for patients with rheumatoid arthritis, elderly patients who can't have surgery. As you rightly pointed out, it's inappropriate for them to have surgery, but they needed to have some quality of life in terms of movement. And we've put them into various braces, from standard braces to gauntlets. Sometimes there's more challenge with those types of patients and more modifications required on the brace. Yeah. Let's see, there's another question there. Oh, Katrina's just saying, sorry, I did not mean bilateral. She meant unilateral, which is the case. I don't see that many bilateral adult acquired flat foot. They're usually unilateral. Another thing to mention would be metabolic syndrome in terms of hyperlipidemia, high blood pressure. And we do see a greater incidence in women, as you rightly pointed out, over a certain age. So quite often linked to high blood pressure, hyperlipidemia, et cetera, et cetera. So.
Oh, Martin, you're muted. I can't hear you.
Sorry, hit the button by mistake there. Yeah, I'm just trying to think what else to say about the Richie brace. In terms, you do have to take a little bit more time with your fitting with the patient. The Velcro straps are important. You will get challenges in terms of medial or lateral irritation, which you need to learn how to adjust or modify. In terms of, maybe we should talk actually about cost as well. These products cost roughly £275 plus VAT. What do you retail them at? So some of the private practitioners struggle with that, and it varies right across the country. I mean, are you happy to share your fees for what you charge in terms of privately?
Well, I know I charge less than you.
Mm-hmm.
No, I mean, it's a difficult one because I feel that these patients need more time. I think your assessment, you need more time. I think your follow-ups, you need more time. You need to talk about loading and fitting the device and, any other irritation, if they're getting an irritation. Personally, I haven't had a patient that's had an irritation yet, because in terms of giving the right advice for fitting, so if we use Richie braces with the tamarack hinge for foot drop, and I've got a bilateral case of that at the moment as well. But certainly when you fit in the braces, it's really important that they bring along the shoes, and you spend a bit of time going through that.
Okay, great. Here's a good question I think everyone will find interesting. It's from Lawrence Bevan. He's asking, who needs a Richie brace? Who needs an OTC brace? Who needs a functional foot orthotic? And who needs an OTC functional orthotic? So these are relevant. I mean, I'd like to jump in there. And this also brings me to the concept as podiatrists to really focus on the median and lateral malleolus. Quite often we trained looking at frontal plane, calcaneal position, also looking, yes, at transverse and sagittal plane, but not above the foot. It was really about the foot. So in our clinics now, if there's any ankle involvement in terms of, we think that the foot condition is being driven by the ankle, we brace it. So we're pretty aggressive with it now. And I had an example the other day. A physio contacted me, and a good friend that both of us know presented with a stage 1 stroke stage 2 adult acquired flat foot. But to him, he thought, look, I'm going to use an OTC product with a heel lift, get her in good footwear, that'll do the trick. My experience now is I'm pretty aggressive with that I go straight for a Richie Brace and we use it for a rehabilitation tool. But that's the mentality of our practice, is that this is what we do. So we get referrals for that. And we've now got orthopedic surgeons referring to us for Richie Brace rehab. And what we're saying to patients is, you're going to wear this for 8 weeks, 10 weeks, 3 months, and then you're out of it, and then you're into functional foot orthoses. So the first part of it, the Richie Brace, is really, there's obvious ones that need the Richie Brace, but from our perspective, it's again looking at the medial and lateral malleolus. And if you see a really prominent medial malleolus, you're moving more towards the adult-acquired flat foot. If you see a really prominent and posterior displaced lateral malleolus, you're moving more to the pes cavus condition. The OTC brace,
as well.
Jump in.
I just want to add in that it's a bit of a bold statement, but in terms of the brace versus orthotic therapy, I mean, I literally had been using orthotic therapy right up until, I don't know, 18 months ago. And then when we started bringing the Richie Brace on board and I started treating patients, it was the difference between, I can potentially discharge this patient at some point, to having a continual relationship with that patient. And I think it's hard to determine how much better the brace is going to be over orthotic therapy, or things like the Muller brace, and like I think the Muller brace is probably one of the better options for like an over-the-counter brace. But the reality of it is, it's the joint coupling that makes all the difference. And
Yes.
Having the orthoses attached to the upright ankle support with the articulation, it's just a game changer. I think the joint coupling and bringing the ankle and foot together in a pathology where the ankle and foot don't like each other is it's a perfect scenario. But you know what? It's a lot of money, and some patients, maybe I want to try this, the Muller brace first. I mean, that's fine, and it's the same as saying, we could try orthoses first, but I mean, a lot of patients come in now and I just say, well, this is how I think, we should treat it. It is the gold standard, for adult acquired flat foot, is the use of AFO bracing. So I think, we need to. Yeah,
and I think you've kind of highlighted there again that in terms of the Richie Brace, it's a podiatric product designed by a podiatrist for the podiatric profession. And I mean, initially it was designed for the treatment of inversion ankle injuries in basketball players. That's what Doug set out to treat. And his colleagues across the United States started calling him to say, never mind inversion ankle injuries, it's really fantastic for adult-acquired flat foot. At that time, they were calling it tibialis posterior tendon dysfunction. So he was like, oh, really? And that's how it evolved. So the articulation of the ankle joint is important, because the uprights, the part of the foot plate that comes up to the medial and lateral malleolus is made uniquely to that person's anatomy. The actual uprights that go in the leg are mass produced, but the key part is the foot component, or the foot plate, which is a podiatric designed custom-made foot orthotic. I think again, the joint coupling, there's various tests you can do to ascertain that disconnection of the foot from the leg. And that's when the Richie Brace is required. The OTC Richie Brace, sometimes I very early in the day, like going back 15 years ago, I would have tried that with orthotic therapy sitting on top of it. To me, it didn't really work. It didn't contour probably the medial and lateral malleolus or get that ankle joint access. When you talk then about, well, who needs a custom-made functional foot orthotic or who needs an OTC foot orthotic, I think that comes down to the practitioner choice. And I think it's very much about pathology. So what is the pathology to make an accurate diagnosis, and to say, okay, what is the diagnosis? And is that liable to respond to something simple like an OTC? Or does that require what you consider more of a custom-made device in terms of something like medial flange, deep heel cup, greater moments of force, either in pronation or supination? So, there's no set answer to that question. Depends on multiple factors. So it's multivariate in a complex scenario. There's a couple of other questions, Zoe, just conscious there's a few come in here. Let's see. There was one there from Sarah O'Connell, and She was asking, what she states is, brilliant presentation, Zoe, very holistic and informative. Did you have much difficulty finding evidence-based conservative therapy? I have found that all papers say you need to exhaust conservative measures, but with very little guidance on conservative therapy.
Really good question, Sarah. I had a look at a few different papers on conservative management. And the one, I cheated a bit and went for a systematic review because I got a collaboration of different papers and comparing different conservative measures. The short answer is no, that there isn't a lot of guidance on what conservative therapy should entail. We all know that orthotic therapy is spoken about a lot with this condition, and we know that the AFO is mentioned a lot, but I'll be honest, AFO sounds a bit like UFO, and people see AFO and think, well, what does that mean? So and that was certainly, I think orthoses, everybody knows what they are, but the AFO, no, they don't. And maybe that is a deciding point that we need to do some research on these patients. We need to do research on different stages of these patients, and we need to show, not anecdotally, but we need to show in the literature that we can get these patients better. There's certainly not enough focused evidence on what to use. So I would wholeheartedly agree. Sarah, you can help me write a study.
There you go. There's a research project for both of you. And there was another question that came in just saying, can you use 3D scanning technology for Richie Braces? And we do have a couple of podiatrists that are doing that at the moment. My clinical business partner, Greg, is doing it. And then there's another podiatrist that I know. So it is moving slowly towards digital capture of the foot and ankle. At the minute, the tricky part is the correction of the forefoot supinatus. There are various gadgets on the market now that can place the foot in subtalar neutral, essentially, ankle and foot at 90 degrees, and then plantar flex the first ray, getting all the met heads on the same plane. They do exist, so it can be done, Okay, well, I think that brings us to the end of this little webinar, and a huge thank you to Zoe, thank you to Connor, and thank you to everybody who gave up their time to be a part of this. Any questions for either of us? You can get Zoe on Instagram, but also you can Google her and find her private practice details as well, and you can get me at Firefly. Also, Zoe, you do have a range of very attractive and very nice creams and lower limb medicaments, so if people are interested in that, they can certainly look it up as well. But thanks very much, Zoe, and delighted that you've had no problems with Richie Braces, which is amazing. So that's incredible. Good stuff. Okay, everyone, have a great day, have a lovely weekend, and take care. Bye-bye.
Thanks, everyone. Thank you very much.